The treatment landscape in myeloma is getting more and more complex, and thankfully actually, because of new treatments coming about that are very effective and actually have some of them very good toxicity profiles in terms of very few side effects. The challenge is really at the moment at which point to give these treatments and in which combinations that are both most efficacious but also affordable by public healthcare systems. And although the UK always sticks out somewhat in that respect in terms of NICE reviews, I think all countries are now facing this challenge because some of the combinations that have been tested in recent trials that have really shown very good and impressive results are difficult to really reimbursed by many public healthcare systems in Europe, but even the publicly funded patients in the US do see that challenge. So what is one fundamental question is really, can we identify factors at diagnosis of a patient before they have even seen a treatment, or maybe throughout the first months of treatment, that can tell us whether one specific drug is really more active than another one. Data on that is still pretty limited in myeloma. We are relatively good now at identifying patients that relapse early, but they have more generic features. These are not features that are telling us whether they should get the one drug or the other drug. We are luckily living in a time where there are several large trials that are now performed that do have a lot of research attached to them. So we are, for example, at the Institute of Cancer Research, we have collected material for one of the largest trials performed in myeloma, myeloma 11, that was using a certain type of drug. And we can now go with really state-of-the-art tools into analyzing this material from the patients in a way that we hopefully identify biomarkers that can tell us which patient particularly benefited from this drug or which patient might have actually benefited from a different drug. We're not the only ones. There are fortunately several of these initiatives around, and we do hope that we can make progress in that. That would be a fundamental step to actually define a treatment pathway, because what we are facing is that patients will probably be having the option of 4 or 5 drugs that are really effective and that really can induce remissions in 50% of the patients. But we want to particularly use the drug in the first or the second line of treatment that are most efficient, because we do know that long-term survival can be improved in myeloma. We are seeing now that 30% of our patients already with the current treatments are surviving 10 years and beyond. And that has increased significantly over the last decade.